Thanks for joining us. I'm your host, Raquel Faria. I am a doctor in internal medicine at the Centro Hospitalar Universitário de Santo António in Porto. Today I'm joined by Professor Sandra Navarra and Bernardo Pons Estel from the Lupus Academy Steering Committee. Sandra and Bernardo, welcome, and thank you so much for joining us today.
Thank you, Raquel, for the invitation.
Today, we are going to discuss a couple of lupus cases and hear your expert opinion on how to approach these challenging situations. The first case we're going to start it's a female mestizo patient that she was diagnosed with SLE when she was 22 years old in 2005. The diagnosis was based on polyarthritis, malar rash, photosensitivity, mucosal ulcerations, positive ANA and anti-dsDNA antibodies, and low complement. She was treated with hydroxychloroquine 400 milligrams a day and prednisolone 20 to 30 milligrams a day for a long time. 5 years later, she was still being treated with more than 20 milligrams a day of prednisolone when she was admitted to the ICU due to diagnosis of lupus pneumonitis in need of mechanical ventilation support. After discharge, she continued more than 20 milligrams of prednisolone. 8 years later, in 2018, when she was 35 years old with a diagnosis of SLE for 13 years, and on moderate to high doses of steroids since the diagnosis, she was first admitted to your hospital, Bernardo. Bernardo, before presenting the admission cause, can you please comment on all the evolution of this young patient during these last 13 years of disease?
Yeah, well, according to her, and beyond her multisystemic acute onset and her flare of lupus pneumonitis 5 years later, she alternated periods of low disease activity and even periods of remission during these 13 years. Mm-hmm. She was always treated with moderate doses of prednisone, but never less than 10 milligrams a day. In addition, the treatment with hydroxychloroquine was very irregular. In fact, during the last 5 years, she didn't take it. She was controlled by her primary care physicians once every 2 years, and it is important to mention that there was no rheumatologist in the region where she lived. Mm-hmm. So for the question that how was admitted, she was admitted to our hospital due to an acute multisystemic flare with the diagnosis of severe lupus flare and or infection.
Sandra, I'm sure that you also have these kind of referrals that with this severe lupus patient being treated for several years, mainly on steroids-based therapy. And Bernardo told us that there was no rheumatology on the area of this patient. So this is one of the unmet needs for SLE. How do you educate doctors on the benefits of early referrals or steroid-sparing strategies?
I believe absolutely I agree with Bernardo, and I relate with him when he tells us about the lack of rheumatologists in the area or the lack of lupus specialists. So here we have a patient who's young, who comes in with lupus and be treated by a non-specialist or a general physician for SLE. And of course, steroids are so available. And the patient has access to steroids. It's readily available. And it has instant relief, symptomatic relief, that is, for these patients, except that on long term, we do have side effects from steroids. And we as rheumatologists don't want to use too much steroids for obvious reasons. Hydroxychloroquine, we give that. It's a fairly modest drug. Now, and that's manageable drug, so that's hydroxychloroquine, but it doesn't really work for many cases, for some cases of lupus, which respond very well to steroids, except for the side effects that we have with chronic steroids. Now, the thing here is that when Bernardo was mentioning about the lack of rheumatologists in the area, we have also, I come from the Philippines, and the Philippines is a third world, it's a developing country. It's limited resources. And for 100 million people, for example, we only have a meager 200 to 300 rheumatologists. So you can imagine, and lupus is also on the rise here. So in this situation, it's so important that these patients are early on, at least during the early part of the disease, are referred to a lupus specialist. So we need to increase awareness among non-specialists, general physicians, primary care physicians. We need to increase awareness among internists, pediatricians also on this, and the educational potential for this disease, physician education potential and opportunities for education is so vast. Yes. So it's physician education is so important. So that is how we address that. And the other thing is networking. So we do a networking of your rheumatologist or a lupus specialist, not necessarily a rheumatologist, but somebody who's well-versed in lupus. In our case, it's usually the rheumatologist in my country. And then you now network the rheumatologist or lupus specialist with a non-lupus specialist for obvious reasons. Mild lupus can be readily controlled under the care of maybe a non-lupus specialist because it's fairly simple. They don't need high-dose steroids. Maybe they don't even need steroids at all. On the other hand, patients who come in with severe lupus will really need to be recognized early during the very inflammatory state and definitely should be seen by a lupus specialist. So again, physician education and start them young. Awareness of the disease. When I say start them young, I teach in medical school, so I need to promote lupus for our young people, for medical students to know about lupus, because it is a disease that pervades every specialization, every field of specialization in medicine, not just rheumatologists. It's a multi-system.
And if young students and young doctors learn about lupus, they will also recognize signs that are not of lupus, but probably with Sjogren's and other systemics or vasculitis, and they know that there is systemic disease, and probably they will refer. So, Bernardo, do you have a network for education in your country?
Well, I agree. I agree with Sandra that education is the main thing. You know, we are talking now at the level of disease modification, but we are not talking about delay in diagnosis. And you know that delay in diagnosis that is between 2 to 6 years. And more in undeveloped regions is closer than 6 years than 2 years, and that impact on the outcome of the disease and different outcomes and damage and mortality of our patients. So education is like a huge point just to we have to take. We have to be compromised with education, not only for patients, but also for, as Sandra said, for primary care physicians, internal medicine, and so on, to get an early diagnosis of the disease and referral to those who knows better lupus. Rheumatologists, internal medicine that dedicate their life to lupus. Lupus is 1,000 faces, and we used to say that when you see lupus, there is no one lupus similar to the other one. Yeah. So education is the main thing.
And then you have several levels of education. One of the things is the awareness of the diagnosis. The other things is the stratification, how to recognize mild, moderate, and severe lupus, to know when to refer and how to refer, and those strategies that Sandra was talking about. So, and then there's the level of when to be aware of when to stop steroids or lower steroids and what to do next. And that should really be done for a lupus expert, and it's really difficult. I'm lucky to work in Europe, but there are all around the world there's an heterogeneity of care, mainly due to lack of specialists and networking in the country. So this is a huge unmet need for lupus all over the world. And let's try to get back to the case, because this patient was admitted due to a severe flare, as Bernardo was telling us. She had fever, fatigue, malar rash, oral ulcers, alopecia, polyarthritis, edema, and she had other very severe, strange and rare manifestations, which were active erythematose, palpable and painful subcutaneous indurated nodules and plaques located on her face, proximal lower extremities and abdomen. Some of them were more than 5 centimeters long, and some of these nodules were also ulcerated. If you count a score of activity, a SLEDAI was 19, and she had several signs of being Cushingoid, not only on the moon face, but also with multiple purplish red streaks. Her lab results, when she came to the hospital, showed slight anemia, 11.8, leukopenia, 2,300, low platelets, 62,000. The ESR was 8, and the CRP was 0.8 milligrams deciliter. The creatinine was a little bit high, 1.54 milligrams deciliter. She had no proteinuria. The hepatic enzymatic values were a little bit high. ALT was 70 and AST was 26. The ferritin was also high, 1,487. She had positive RNA with a speckled pattern. She had positive anti-Smith antibody and negative anti-dsDNA antibody, and the complement C3 and C4 were a little bit lower. She did a CT scan of both thoracic, abdomen, and pelvis, and an echocardiogram that showed no relevant abnormalities. Blood and urine cultures were negative, and the skin ulcer culture showed a proteus mirabilis sensitive to cotrimoxazole. The deep skin biopsy showed extensive lobar lymphocytic paniculitis with deposits of IgG, IgM, C3, C4, and fibrinogen. Bernardo, we can now assume that the patient had a severe lupus flare despite having low ESR, and she's infected. These widely spread erythematous nodules are compatible with lupus paniculitis, and the biopsy confirmed it. But how often do you have seen lupus paniculitis this severe as this patient? Or do you worry that the biopsy could be underrepresenting all the skin lesions? Are you considering and worrying about other kind of diagnosis, even with these biopsy results?
Well, I can say that lupus paniculitis is a rare condition, and in most of the whole cohort is between 1 to 3%. And in our cohort, in the Gladel cohort, was 1.4%. And the second, with this severity, I think is extremely rare condition. We have only 2 cases in 1,480 patients that we follow during 10 years. Regarding the underrepresenting all the skin lesion about the biopsy, in order not to lose information, the skin biopsy must be extensive and deep enough, as was done in these cases. In this case, show extensive lobular lymphocytic panniculitis with deposits of IgG, IgM, C4, and fibrinogen by immunofluorescence. And regarding your last question, if we consider other diagnoses, I can say that it's always important to think about other diagnoses, differential diagnoses, such as Weber-Christian disease, subcutaneous T-cell lymphoma, mycobacterial infections, deep fungal skin infections, such as, for instance, histoplasmosis, that occur mainly in immunocompromised patients. I think those are the main concepts.
Thank you, Bernard. Sandra, you notice in my voice that I was not so comfortable with low ESR and CRP in this patient. She's infected. Do you feel comfortable with these lab tests and this patient with these infections, such an extensive lupus panniculitis? If this patient lived in Philippines, what would be your differential diagnosis?
The picture of this patient is that of a very bad panniculitis. And I would look at the inflammation that's coming from the panniculitis. If you do have, this patient does have a culture result, but it's a culture coming from the skin. It's not culture coming from the blood.
Yes.
So you start thinking of whether whatever grew on skin culture, you'll have to think of other maybe possibilities like contaminants.
Yes.
So it's different when the culture is positive from the blood, especially if it's 2 sites, 2 blood extraction sites that gave you a positive culture growth. So that's my comment. This is why when I was hearing the case, I was thinking really more of very, very active panniculitis, lupus disease. I would go into very similar situations. I agree with Bernardo. You'll have to think of Weber-Christian. You'll have to think of malignancies. So is it something that we are now looking at into a malignancy? Because if we'll just look at the ESR and CRP, first of all, these are non-specific acute phase reactants. And between ESR and CRP, CRP is a bit more specific and gets more elevated when you have an active infection, less likely when you have active lupus. So sometimes they use the ESR and CRP ratio. So if you have a high ESR CRP ratio, in other words, your ESR is way up and your CRP is just on the normal side or slightly high normal, just very slightly elevated. And you start thinking, this is more of flare. This is more of disease flare rather than infection. So that's how we differentiate this in the clinics, I mean in clinical practice.
Bernardo.
Yes, let me tell you that we also measure procalcitonin that was normal in this patient.
So it assures more that probably the infection is not a main thing in this particular case. Yeah. So the patient was treated with 3 days of 500 milligrams IV methylprednisolone, high-dose IVIG, immunoglobulin for 5 days, mycophenolate 1 gram daily. She maintained hydroxychloroquine, and she maintained also the 20 milligram of prednisolone just for now. She did also endovenous IV imipenem and vancomycin antibiotic, and then she went home to do an additional full dose cotrimoxazole for 5 more days. She was discharged from the admission without fever, and her skin lesions clearly were improving. But 1 week later, she was readmitted with fever, lymphadenopathy, hepatosplenomegaly that she didn't have on the admission CT scan, if you remember. She had reactivation of the severe indurated lesions, persistent pancytopenia with the appearance of petechia, purpura, and ecchymosis. The lab results showed now an hemoglobin of 8.9, low platelets, 65, ESR was a little bit higher, 21, fibrinogen was 156, her ferritin was a little bit higher than the previous one, 1,991, sorry for this, and triglycerides of 258. Sandra, this is not going well with this patient. So in all your differential diagnosis for this admission, 1 week after discharge, would you consider cotrimoxazole toxicity or hypersensitivity as an hypothesis for the clinical picture? What is your experience on using cotrimoxazole in lupus patients?
Yes, cotrimoxazole can cause problems including hemolytic anemia, especially in lupus. And cotrimoxazole also has a propensity for interacting with the bad drug-drug interactions, which we need to watch out for, especially if you give cotrimoxazole in a patient who is on methotrexate, for example. So those are the things that you need to watch out for. But these patients, yes, I agree that you will have to consider that. But see, it will not give you a cotrimoxazole reaction per se. Will not give you the hepatosplenomegaly. So I think this is really something else more than just a drug side effect.
Bernardo, do you think that this could be from cotrimoxazole? What can you add, please, some comment on what's your experience with cotrimoxazole in lupus patients?
Yes. When we indicated trimethoprim sulfamethoxazole, we considered that adverse events may occur, and mainly hypersensitivity reactions may occur. Such as Stevens-Johnson's syndrome, toxic epidermal necrolysis, fulminant hepatic necrosis, agranulocytosis, aplastic anemia, and other discussions. We never had this kind of severe reactions in our patients. So we don't use this kind of drugs extensively in a high doses, but these kind of reactions we read on the books, but not in our patients.
Okay, that's a good insight from the experience point of view. Continuing with the case, after this new flare that is really different from the others, with fever, pancytopenia, hepatosplenomegaly, lymph nodes that are increased, and we know they were not there before. The bone marrow was shown and documented to no signs of neoplastic infiltration, and it had macrophages with signs of hemophagocytosis, as probably all our listeners were also suspecting this. She was treated with IV dexamethasone and rituximab 1 gram. Despite treatment, she remained severely ill with fever, asthenia, petechia, and purpura on her abdomen and thighs, and pancytopenia. So, having an hemophagocytic syndrome, the etoposide was also started, but unfortunately, this patient died. So when we were listening to the case, all of us were worried about where is this going on? And we now know more of hemophagocytic syndrome, HLH, early detection and treatment than we did know 5 years ago. And it still is a new challenging. Calling this entity different things like macrophagic activation syndrome, for example, in SLE and Stills, or primary or secondary HLH in other conditions, actually decreases the early detection and management, since independently of the underlying disease, the initial approach should be the same. In SLE, the mortality rate is not as high in HLH flares than in other diseases like lymphomas or even in the primary HLH. And the most recognizable risks in lupus are infections or infection-driven SLE flares, and the mortality is higher in infected patients. It looks like several triggers at the same time can also happen, and they should be pursued. As Sandra was saying, that probably we should think of other kind of things than only an infection that was caught on the skin. I feel particularly uncomfortable with the possibility of this patient having had in other places of the paniculitis, a complication of lupus paniculitis with paniculitis like T-cell lymphoma, and that being one of the triggers for this HLH outcome. So, Bernardo, when you received this patient, she was already in very bad shape. You did what you could in the short time unfortunately, she died. I'm sure that you and your team suffered with this and discussed this outcome. I don't know if you have in your centers this kind of morbid mortality discussion to piece everyone. But looking at the case now, what else do you think could have been done in this patient in the light of 2023? If she had presented last week, for example, and not 5 years ago, would the outcome could be different, doing something different than what was done 5 years ago? What do you think, Bernardo?
Well, I can say that the background of this patient is really essential, is really important. Mm-hmm. Based on my experience, I would say that being mestizo is what in the United States called Hispanics. Mm-hmm. It's a mixture between the European and the indigenous people in Latin America. Mm-hmm. So being mestizos of low economic status and low educational level is a load of bad prognosis. That is a principle. And we cannot do much more on this side. But anyway, I believe that the basis for changing the outcome is the education. As we said at the beginning, education of the patient, the primary care physicians, internal medicine, in order to what? In order to achieve an early diagnosis and referral to those people that have experience in lupus. We can call rheumatologists. We are mainly rheumatologists in my country, in Argentina, just to modify the disease outcome. Again, education is important to achieve adherence to treatment like hydroxychloroquine or immunosuppressants. And if the health system and the economic situation in this case allow use other disease modifying drugs earlier, we can use many other drugs. For instance, belimumab. In this case, it would be a good choice. Finally, I want to remark an essential concept. As Sandra said before, steroids is clinical needed. If clinical needed, they should be prescribed at the lowest dose and for the shortest period of time.
So this patient didn't die exactly from the HLH. Actually, all the prognosis was based in all the management from the beginning, if I understand exactly what you were commenting.
Yeah.
Sandra, do you have any comments additional comments on this difficult, challenging, unfortunate case?
I would like to reinforce the fact that we don't know exactly what went wrong after 13 years of the disease. It's only now that this patient has a very, very bad, apparently lupus flare. It's a very bad lupus flare that went on and transitioned into an HLH, and we could not entirely exclude the possibility that this patient has gone on into a hematologic malignancy, like a T-cell lymphoma. So it's a paniculitis-like T-cell lymphoma. So those are the things that's happening, and it's rather towards the later part of the lupus picture. So something went wrong to trigger these final events. And one of the things that comes to my mind is, was this patient that immunosuppressed to have infections? And those infections and immunosuppressed from the steroids. So she may be Cushingoid. There's just too much steroids. And steroids can just immune suppress the system. That makes you very prone to different kinds of infections, including, I'd like to emphasize that if you have HLH and if a patient has considering lymphomas, hematologic malignancies, one of the triggers that is common to lupus and common to lymphomas and hematologic malignancies would still be your Epstein-Barr virus. We know that lupus is triggered by Epstein-Barr virus. We also know that lymphomas and hematologic malignancies are also triggered by Epstein-Barr virus. We know that HLH can be triggered by Epstein-Barr virus. Now, that is difficult to establish in the clinics because you'll have to do serology for these patients, which is not readily available in terms of viral infections. Now, if you have a viral infection of Epstein-Barr virus, I'm not an infectious disease, but maybe if this, I'm not with infectious diseases, but one of the things that comes to mind is that would we have been, if we had this, if there's a diagnosis of Epstein EBV in this patient early on, and with addressing the EBV, would have prevented this downhill course, very active course of this patient.
You're absolutely right. And mainly because EBV reactivation is really, really difficult to diagnose, not only with serology, but it needs viral load and it's not available. So few centers have an EBV viral load test to be available on the clinical. So it's really, really difficult to diagnose and then to treat, because antiviral therapy is not okay. Rituximab can be okay for EBV, but it comes back a few weeks then. And it's not only a trigger, but also a perpetuating of HLH when the HLH is being treated. So it's an excellent hypothesis for these severe HLH patients. Thank you.
And I start to think, I always, just to emphasize and reinforce also what Bernardo said, those steroids, if this patient probably wasn't on long-term steroids, wasn't immunocompromised, didn't have all those other side effects, that because we used early on a steroid-sparing agent early on for the lupus, maybe something like this could have been prevented.
Thank you so much. Let's dive on the second case, which is going to be a little bit shorter than the first one. So the second case is from your cohort, Sandra. So this female was diagnosed with SLE when she was 22 years old in 2004. She had alopecia, malarash, oral ulcers, photosensitivity, anemia, low platelets, proteinuria, low C3, ANA positive, and anti-dsDNA antibodies positive. Soon after her first presentation, she had lupus nephritis and neuropsychiatric SLE, and she was treated with cyclophosphamide and then azathioprine maintenance treatment beside hydroxychloroquine and steroids. In 2021, she had an eventful pregnancy, and lupus was clinical quiescent since her last clinical visit 2 years earlier, despite she was poor compliant with medications and a follow-up lab monitoring. Sandra, shortly, how would you advise SLE young women when they want to become pregnant? Do you have a preconceptional work in your center? Is there a particular lab that you want to pursue when lupus patients want to become pregnant?
Working up a patient, it's a very necessary thing in any female patient in the reproductive age group. And we know that pregnancy is a very important issue in lupus, simply because these patients are in the productive age group. So counseling should always be there. And the best scenario would be to prepare these patients, counsel them, and to control their disease at least 6 months. So meaning to say, these patients at its best would be remission of the lupus for 6 months prior. So that's 6 months prior to conception. But that is the ideal situation. Most of the time, it is not followed. So patients just come in and they say, oh, I'm pregnant, and I'm pregnant, and they have active disease, and sometimes they don't even know that they're pregnant. They just come to you, and then they tell you, oh, okay, so how are your menses? Oh, my last menstruation was 3 months ago. And then you do a pregnancy test. So it's so easy to get pregnant. So and it's especially for, these are young females.
Yes.
So it is so important to give them education and give them counseling. So that's so important. Now, in the case, so that is in general. Now, this current case, the preconceptional workup also we'd have to look at your antiphospholipid syndrome. That's relevant. The other workup that you will need to look into is its effect on the baby, as in raw or antibodies to raw or to La, which would have an impact on congenital complete heart block. So those are the important workup if you have the chance to work these patients up prior to conception.
Bernardo, do you have a preconceptional clinic, or how do you advise the patients on Argentina?
Yes, we do. And also we always keep in mind that education, as Sandra said, is a priority again. Multidisciplinary preconception evaluation is recommended for all patients with SLE, antiphospholipid syndrome, or asymptomatic carriers of antiphospholipid or anti-RHO and anti-LA who express pregnancy desire. We always evaluate comorbidities, damage accrual by lupus or by its treatments, and we should review the medication that she is receiving, and also the medication she should receive for pregnancy. We have to keep in mind that our situations, because we changed a lot in the last 20 years. 20 years before, we said lupus patient cannot be pregnant because it's dangerous, and so on and so on and so on. Now we said yes. The ideal number, the magic number, is remission during 6 months to 1 year before keeping pregnancy. And of course, we have to remember that some accrual damage that is absolutely contraindicated for pregnancy, such as pulmonary hypertension, heart failure, severe kidney disease, and severe thrombosis in the last 6 months. So yes, we have multidisciplinary preconception evaluation that is recommended for all young patients that want to become pregnant.
Perfect. 5 months after the delivery, while she was taking irregularly hydroxychloroquine and azathioprine, she consulted for treatment of a localized soft tissue abscess, which resolved with oral antibiotics. At this clinical visit, there were incidental findings of polycythemia. Her hemoglobin was 18, and she had 3 crosses of proteinuria. Though she denied having any symptoms, she admitted to a largely sedentary lifestyle after she delivered, to which she attributes to occasional episodes of dyspnea on exertion. She refused to be admitted and agreed to do a further workup as an outpatient clinic. A week later, she was brought to the emergency because of chest pain and shortness of breath. Abnormal physical exams finding included tachypnea, tachycardia, distended neck veins, dynamic precordion with peristernal heavy and accentuated S2 sound, B-basal lung crackers, and grade 1 bimalleolar edema. Lab tests showed, again, polycythemia of 18, proteinuria 3 crosses that actually were related to more than 5 grams a day of proteinuria. She had normal creatinine, troponin, and the arterial blood gas were also normal. She did an X-ray that showed cardiomegaly, and the EKG showed sinus tachycardia with right ventricular strain. She did an echocardiogram that showed concentric left ventricular remodeling and a segmental wall motion abnormality, which were a kinetic anterior and lateral alterations. The left ventricle was dilated, elongated, and she had a right ventricle hypertrophy with depressed systolic function. The ejection fraction was 29%. The pulmonary artery systolic pressure was 91%, 91 milligrams of mercury estimated. And other findings included a dilated auricular, right auricular, dilated TV annulus, and moderate tricuspid regurgitation. She was managed initially for cardiomyopathy, severe pulmonary hypertension, and chronic thromboembolism. Sandra, pretty severe and also very, very rare presentation of a lupus patient, young lupus patient, after delivery, 5 months after delivery. With these abnormalities, what do you think were the main differentials, and how would you proceed to the etiology workup? In your center, do you perform right and left catheterism?
Okay. I have to put in perspective what happened to this patient. This is a patient who has been well.
Yes.
5 months ago, delivered, and she was very happy. My first child, normal spontaneous delivery, normal chest x-ray, everything was just normal. I mean, she was in absolute remission. She was not on steroids. She was just on hydroxychloroquine. And once in a while, she would take her azathioprine. So urinalysis was entirely normal. There was no proteinuria at the time of delivery. That's the picture. That is the happy picture of this patient when she delivered. That was 5 months ago. And then 5 months later, she just comes in. She's short of breath. So something happened between delivery and 5 months later. So we're not sure what happened there, but we now know that we have a patient who's polycythemic of 100 or 180 grams per liter. That's very high. That's polycythemic.
Yes.
Which doesn't fit into a picture of a lupus flare. You have proteinuria, fine. Is proteinuria, maybe this is likely lupus nephritis. So an activation of lupus nephritis. But I am intrigued by the very high, she's highly viscous with that polycythemia of 180. So something's going on there. And you now have evidence that something's going on focusing on the heart and the lungs. Because here we have a new onset cardiac problem with a low ejection fraction. And this is a patient who has high cardiomyopathy. You have hypokinetic wall motion. And something's going on with that heart. And the more important thing is you have a whopping increased pulmonary arterial systolic pressure. So if that is what you see 5 months after an entirely, absolutely normal spontaneous delivery with lupus in remission, something was going on in between already. So, which will explain the polycythemia. So polycythemia looks like a secondary kind of polycythemia in this patient because this patient was already relatively hypoxemic for some reason. And that hypoxemia is coming now from your from your cardiomyopathy. That hypoxemia was also coming from your very, very high pulmonary artery pressure. So all of these are leading to this patient's current symptoms. So yes, definitely she is one who will deserve catheterization. And we were planning for that in this patient, but we just didn't have the time to do this because she just went downhill 2 days later, 24 to 48 hours later. But that is ideal. You should be performing right and left heart catheterization.
Bernardo, do you have the same approach in your center? In this clinical picture, would you program a left and right catheterization?
Yes, indeed. But I want to not to make a question, but I was questioning myself in this case that there are 4 findings that worry me. The main 2 is the sedentary lifestyle that this patient has postpartum. And the other thing that was polycythemia. I don't know if polycythemia has something to do with this case, but we know that is a predisposing factor for arterial and venous thrombosis. So those 2 things make noise to my mind when I saw the case. Of course, she has dyspnea on exertion, and also she has an active disease because she has proteinuria. So in our center, catheterization specialists prefer to perform radial real-time imagings compared with the standard real-time images because they said that they get a better global image quality. So this is a case that we have to interact with other specialists. Is not only for rheumatologists.
Okay, and the patient actually, as Sandra told us, she didn't have the opportunity to do a catheterization because unfortunately, after starting therapy for pulmonary arterial hypertension, she progresses and died a few days later. If she, and of course, you presented 2 very important points that she could have had a pulmonary arterial hypertension related to lupus, and then with the polycythemia and the sedentary lifestyle, developing a chronic thromboembolic disease on top of that. So these are really, really difficult cases. In this case of this patient, do you have a pulmonary arterial hypertension reference center where you do send these patients, or do you treat you by yourself with the specific vasodilators for the hypertension, Sandra?
It is not exactly a formal center, but we do have these cases, and these are the patients we refer to the specialist. So we have a specialist for that, and they are on the lookout for these cases. We are aware of what they give for these patients. There's a protocol for that on how to treat pulmonary arterial hypertension. So you can go sildenafil, you have bosentan to start off with. So those are the things that they start off with. And that is what we have available in our centers. But most of the time, when you have severe pulmonary arterial pressure like this, we know that in lupus, the course of pulmonary arterial hypertension in lupus has considering that it is more of an inflammatory state versus a fibrotic state. In contrast to pulmonary arterial hypertension, as you would see it in systemic sclerosis, it seems to have a slightly better prognosis in patients with lupus if you catch it early. That is in contrast to the PAH that we see in systemic sclerosis. And I would also want to just reinforce what happened there is after, if this patient maybe had a more active lifestyle postpartum, so maybe the symptoms would have been detected earlier.
Yes.
And this patient could have undergone workup earlier, and we would not have been caught by surprise when this patient came in. So those are my insights on this case. And lupus is something that really has surprises, and that patient is very individualized. We also note that in this particular patient, you have a patient that's long-standing lupus, has had flares, predictable flares almost. But this time, it just didn't work for her. So, and then there are mechanisms also on the proteinuria. Also on the proteinuria, there are reasons to think that the proteinuria here may not necessarily be coming from an active lupus nephritis, because there are and the primary reason or the primary focus for these patients' current problems is really the cardiomyopathy and pulmonary arterial hypertension.
Yes, not the
flare
itself.
Yeah, not the nephritis flare, because there are reports and there are plausible mechanisms by which you can have proteinuria secondary, not to a lupus nephritis, but secondary to the cardiopulmonary symptoms, but especially in patients with heart failure, you can have proteinuria secondary to that.
Thank you so much. Bernardo, do you have any additional comments and final comments to this case?
Well, I can say that pulmonary arterial hypertension is a very rare condition. In Gladel cohort, during the follow-up of 10 years, we have 1.4% of patients during the evolution. So as Sandra said, and I think she will believe me, and in my country also, in Latin America also, we have every drug to treat pulmonary hypertension, sildenafil, bosentan, and many others. But you know what? We have in the country, but the patients sometimes don't keep it, don't take it, don't get it, because the system is very difficult just to get all these patients with those expensive drugs. So I want to say finally in this case that as I said before, education is the meaning. Education is the column of our. We can change just to modification of the disease. Education, education, and education.
Even with the rarer manifestations, it's such a huge unmet need. You need to educate on the most common manifestations. You need to educate on steroids and other drugs. You need to educate on rare manifestations also. If you don't feel okay, you need to go and find your doctor. That's really that's a lot of work that we have to do in lupus worldwide. Thank you so much for your insights on these two very difficult cases. And they showed rare and severe SLE manifestations and also consequence of steroid damage, as we discussed during the old podcast, both in the short term and in the long run, and the risk of erratic compliance to treatments also. To our listeners, we hope these discussions have helped you gain more of an understanding of lupus. Do send us feedback on cases you would like us to discuss in the future. Thank you so much for listening. We hope you enjoyed this podcast. Please leave us a review, which will really help us in reaching as many of your colleagues as possible around the world. Join us again next time.